All right, without further ado, though, Dr. Valerie Kanter, hang on. I want to give her bio here. Board certified endodontist and naturopath. She graduated from the University of Florida College of Dentistry with her DMD and MS. She's a third-generation dentist with licenses in both California and Florida. She teaches advanced clinical endodontics at UCLA, where she is engaged in research to explore the benefits of ozone and laser applications in root canal therapy. She enjoys the opportunity to help students acquire real-life clinical skills beyond those that are taught in a classroom. Dr. Kanter advocates a patient-centered, biological, and integrative approach to endodontics. So while Dave is finishing up here, Dr. Valerie Kanter.
I am honored to be here with you guys. How many of you have seen me speak before? Maybe at the last IAOMT. Okay, cool. I'm going to try to get into some of the stuff I didn't get into last time. That was one of my first big presentations here. It was definitely quite an honor, and I only got through about half my presentation, so I've been really on point with timing sense, but I do have a ton of information, so I'm going to dive right in and get started. I want to talk about keeping teeth vital. That's my passion, is actually regenerative endodontics. I might be the only endodontist out there, but I have found one more recently, and I'm actually going to show a case by him. So these are some of the key components up here on the screen. I have my laser. I talk about nutrition with my patients, and of course, ozone is critical. And then understanding the tooth anatomy. Okay, so we all know that the mouth's connected to the rest of our body. I'm not going to tell you guys anything that you don't already know. I'm talking to the right group here. But there is an imbalance of the oral ecosystem when we see things like this, when we see this gross decay, especially in kids. And we know that there's a systemic theory to caries too. It's not just the traditional one we were taught in dental school. These acids from bacteria are actually unable to destroy the collagen. It's our own MMPs that break down dentin and cause decay. Dental decay is an uncontrolled inflammatory autoimmune breakdown, just like periodontal disease. There's a dental fluid flow, and it's regulated by an endocrine portion in our parotid gland, actually, which receives signals from the hypothalamus. A healthy tooth is nourished by blood supply to the pulp. The dentin is nourished by the centrifugal outward fluid flow through the tubules. But that can get disrupted. So when you have free radicals and increased ROS in our system from sugar and stress and lack of sleep, I'm talking to myself on that one, we can actually reverse this process, and the fluid flow starts going in the opposite direction. So now we have, plaque on the teeth, and we have this internal system. Both of these two things together are combining to cause this imbalance in the oral ecosystem. And these pathological alterations can happen when our terrain is not on point, okay, when we don't have that homeostasis. And if our extracellular matrix looks like this, we have a major problem. And then all of these cascades start to go on in our body. And specifically, this one is really important when we look at the macrophage. And I'm going to teach you guys something I just learned a couple of days ago from one of my best friends, Dr. Rick Miron, who's like the PRF guru. And I know he wanted me to let you guys know he couldn't be here today because he had another speaking engagement, but his brother is here with the BioPRF table, so you guys should all go meet him and check it out. This is what he shared with me, and these are actually his slides, about the immune system in the body. Obviously, we know periodontal disease is linked to all of these disorders. Now we're realizing that even more, everything in the mouth is. And it's all from a regulation actually between macrophages. We're flowing between these two stages of macrophages, M1 and M2. M1 is causing havoc in our body, and M2 is helping the healing process. How do they break this down? Well, this is one study that looked at that. They basically, this was just done in 2018, they tied a ligature around a tooth right at the CEJ area. They caused some inflammation in the sulcus by doing that. You started to see bone loss, of course, and then when they took it off, the body was able to regenerate. This is that pattern that you're going to see. Okay, so you're going to see a loss in bone here, and then you're going to see when it starts to regenerate. So they took these two medicaments that they knew. One eliminated macrophages completely. The other medication drove the macrophage into the M2, the healthy direction. Now, when they put the medication in that completely wiped out macrophages, this first slide is showing us, could we prevent the bone loss in that first stage after we tied the ligature around? Well, as you can see on the middle one, this is the one that completely wiped out macrophages. So when there were no macrophages in the area, there was barely any bone loss. This is important. Now, they tried to just drive the macrophages into the M2, and they did prevent some bone loss, you see here on the right, but not as much as if they completely wiped them out. So by completely taking away macrophages in the area, you can prevent bone loss. But obviously we need macrophages, right? On this next slide, they did this during the bone regeneration phase. And actually when they drove the macrophages into M2, it actually really increased the bone regeneration. But if you wiped them out completely, you didn't get that much bone regeneration. So we can see this balance and how important these are. And I just wanted to quickly touch on that so you guys really understand this is an issue with our immune system. And so what's behind that? Well, when you start thinking about functional medicine, people that have missing teeth, this is the curriculum that they learn, the functional medicine doctors. And if you have missing or, like, let's say decayed teeth, you're probably having an issue with vitamin A and vitamin D. And we already knew that through a lot of work from Weston Price. And this is one of my mentors who I mentioned a couple of years ago, Dr. Jay Levy, and I highly recommend you guys all look into his course on occlusion. He taught me about Weston Price from the beginning, and he's quite brilliant. His idea of holistic dentistry is about promoting a state of health in the chewing system. It's about trying to figure out how a patient's teeth and chewing system evolved into its current state and extrapolating the patient's dental future with and without intervention by the dentist. It's about customizing preventative and restorative dentistry to suit the conditions of the patient, as well as customizing dietary and chewing habits. Holistic dentistry is about helping people to maximize the longevity and health of their chewing system. Love this man. So what he taught me is this shouldn't be happening to our teeth. We shouldn't be cracking teeth like this. So why is this happening? It's happening because there's competing sensory information and management of tactile sensory information. And we know that this goes back to the way that our jaws are forming. We're deficient in a lot of vitamins. This modern diet and these refined foods, our jaws aren't developing. We don't have enough room for our teeth. We're getting caries and we're getting crowding. Osteoblasts secrete osteocalcin in response to the presence of vitamin A and vitamin D. So if we don't have enough of that in our diet, K2 can't even get activated. These are some studies that talk about that in much more detail. And so what's going on? We're obviously deficient, and we need vitamin D. It absorbs calcium, it helps our bones, it helps our teeth. It plays a role in muscle function and immune function, and also helps lower all of these disorders that we see, all these systemic disorders. And what Rick just shared with me, and I hate to steal this slide from him, but I had to show you guys, and I think he would be happy that I did, is that if you look at this chart, this is talking about implant failure. Now that's not on the topic of what we're talking about today, but this is telling you how critical vitamin D is. Vitamin D was a higher risk factor for a failing implant at 11% over diabetes, over smoking, and over periodontal disease. Almost double all of those. So the risk factor is in vitamin D. And the problem is most people are deficient. And it's connected to all of these disorders. All of these disorders you see, asthma, depression, everything. It's all connected to this nutrition that we're missing in our body. And of course, it's connected to caries. This is a national cross-sectional study in Canada. They looked at over 1,000 kids between 6 and 11, and they obviously saw a correlation between caries rate and low vitamin D. And this is the US population, you guys. We're all deficient, especially in vitamin D. And then we go and do stress and dental work on our patients, and that level drops even lower. So what are we going to do about it? Well, obviously, we can talk about food all day long, but we all know that our soil is deficient of all our micronutrients. We're not actually getting everything we need from food. We've got to supplement. And there, right outside, you guys, into the exhibit hall, we have this new medication that Dr. Miron actually promoted just for this, for bone and teeth health. And it's got a ton of nutrients. There's a morning formula. There's an evening formula. So you give these to your patients. These doses are so high in these medications, you can't take them permanently. You only take them like before these big surgeries. Before you're doing that cavitation surgery or doing that large implant full reconstruction case, you need to make sure your patients are taken care of. I know you guys all know this, but I just want to tell you, I was going to have 10 or 15 slides of different supplements up here today, and he shared with me this new thing, and he showed me the statistics and how the numbers are increasing in the blood work after they've just been testing this. And this man is brilliant. And I'm like, you know what, Rick, you did a great job with this. Thank you. So it's called Dentamedica, and it's down there, out there at the exhibit hall. It doesn't have a couple things in it. I had to leave my slide up on CBD. This is really great for pain and inflammation. And this is a paper in the JOE, the Journal of Endodontics, talking about CBD. And our odontoblasts actually have CBD receptors on them. So you gotta love it. And I live in California. It's highly accessible to our patients and everyone's asking about it. It's in Whole Foods. This is the brand that I recommend. This is called 7 Schools by Elemental Wisdom with a Z. It's an incredibly powerful full spectrum CBD. There's a discount code if you guys want. It's called at Dr. Val. And JOE also put a paper on omega-3 fatty acids. This paper really lit me up. They basically took a bunch of mice, they exposed the pulps, they caused inflammation in the pulps. Then they looked at all of those oxidative stress markers, those cytokines, those IL-1 betas. The little mice that ate omega-3s for a month before the procedure had significantly lower inflammatory markers in the body. I was so thrilled. And so I found this incredible DHA and EPA product that I've been giving to my patients called Symbiotica. This is a vegan source from microalgae, incredible product. It's called Symbiotica with the C. And again, I was like, I loved it so much, I set up a discount code with them for my patients, Dr. Val. So why does all this matter? Why do we need these nutrients in our body? Why do we want to keep these teeth alive? Of course, you guys all know the answer. We want to regenerate these things. Okay, because of the immunological and sensory function of the pulp-dentin complex, and I've touched on this many times before. The pulp gives us fast reactive responses to the chewing system. It really lets us know what's going on. So if we can keep the teeth vital, we can keep that going, and that's important for this plex complex. Also, we use the blood vessels in the teeth to facilitate exchange of fluids, nutrients, waste products, and cell signaling molecules. So with all of this going on, we obviously have nutritional support that's really, really important, but we all want some practical stuff that we can do in our office too. So of course, ozone plays a role in that, and I'm going to show you guys how and where I inject that. Also, homeopathic cocktails that I learned from my naturopathic course has been really critical in reversing a lot of pulpitis cases. And low-level laser therapy has been indispensable. So there's tons of papers out there on dental applications of ozone, okay, and how to clean out cavitated areas. And I'm going to just show you guys a few pictures to show you my setup so you can see how I do it. So basically when I have deep caries, I use one of these handpieces by Salvin. Longevity sells it too with their units. I do ozonated water rinses. I activate that water with the laser, which I'll show you guys in a moment. And then I do direct gas onto the area. So sometimes if we're dealing with small little areas of caries, we can just use a little tip like that you would use on your etch tip, hook it onto the handpiece, and place it there right into the grooves. And PromoLife has this awesome little cupping system too, so you can really encapsulate the tooth that directly hooks onto the handpiece as well. And then I use those homeopathics and I mix them with procaine and I mix them with ketone and those minerals, and I give the body really what it's asking for. This liberates oxygen and it resets the membrane of these cells that have been firing pain, 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 because it has the same electrical charge of a resting membrane. And the homeopathics, as you know, Tramiel, and I'll go through a couple of them with you guys, are really wonderful. They re-regulate the tissues, they decrease inflammation, and they help lymph drainage. And I don't just inject it right around the teeth. I think this is where people, have issues. When you put the ozone just at the apex, how much is really diffusing through a heavy intact cortical plate. So I use the autonomics to my favor, and I learned this from Dr. Malika, and I thank him every day. In the sky, Phil, I don't know if you hear it, but I'm thanking you because I've learned so much from that course, from the IAOMT class and from all of his ozone courses. So there's a few ganglion that we hit during these injections, the submandibular ganglion, the pterygopalatine ganglion, and the otic ganglion. And when I hit these autonomics, it really distributes the medicaments and the ozone directly to the entire region. And these whole regions have been lighting up, you guys. And so here's a slide on Tramiel and all the incredible homeopathics that it involves. And here, so I keep my system nice and organized at the office so my assistants know what to grab and they can easily go in and get what they need. And we use different combinations for different things. Sometimes I actually inject it directly into the PDL. So I have the wand system or the STA. I make a little cocktail of all these. I inject it back into an anesthetic carpule, and then I place it right down the ligament. This specific case is a brother of one of my very, very close friends that I talked to and gave him girl advice on way too long last night. I wanted to just say, you know, why is he? I gotta go to sleep. And this is his brother, and we had a pulp exposure, we treated that, we reversed all of his symptoms, and his tooth is vital. This is a picture of a tooth getting low-level laser treatment. How many of you guys have diode lasers? All of these diodes can do low-level laser treatment. Even if you don't have even if it's not like a setting on your laser, you can talk to me about it. Usually somewhere in the range of 2 watts is a good safe number. And you can just treat about a quarter size per 30 seconds per quarter size around the area, not touching the tissue, but just penetrating. If the patient feels heat, you back off a little bit or you turn your watts down. But this really is doing a lot of work inside. This light energy is turning into cellular energy. It's hitting the mitochondrial photoreceptors. The photochemical process in the cell gets activated, you start to get more DNA synthesis, more cell proliferation and oxidative phosphorylation. And then what does that result in? More ATP production, more mitotic activity, fibroblasts start to duplicate. So all of this is happening, and basically we're getting less inflammation, more drainage, and the teeth are starting to feel better. Now there's a lot of different lasers out there. My favorite one happens to be at the 2940 wavelength. This is critical for dentistry. 2940 is the peak absorption of water. Now, I didn't know anything about lasers a few years ago, you guys, and I know it seems confusing maybe to some of you who've never picked up a laser before, but here's the bottom line. There's a bunch of lasers on the market, and they all fall somewhere on this spectrum of wavelength. Wavelength is the most important thing when you're buying a laser. So 2940 is at the peak absorption of water. What does that mean? When the light hits water, the water explodes, okay? So why is that important for dentistry? There's water in everything. In our gum tissue, in our teeth, and in the solutions that I irrigate teeth with, it's all water. So this is the laser that I recommend. Lightwalker, they actually are here, which I'm just thrilled. I don't know if they've ever been in a meeting like this. And I do all of my vital pulp therapy cases with this laser, as well as everything else I do in endodontics. I'm not kidding, pain-free cavity preparations. There may be other lasers that tell you they can do that. I talked to the doctors that have purchased them, they've struggled. This one absolutely can, and I'll show you some cases. Deep dentin disinfection. When you're drilling down in those deep carious areas with a burr, I hope you're changing your burr every 5 seconds, because it's just carrying the bacteria down deeper and deeper closer to your pulp. Think about this. Endodontists that do vital pulp therapy with handpieces, they have 10 burrs lined up, and they're changing them with sterile gloves each time as they go. So you guys are wondering why aren't these pulp caps working? Why aren't these pulpotomies working? Bacteria. It's a major issue down there. So we want to be conservative. So the laser is incredible for that. You can literally see layer by layer as you start to remove the tooth structure. No post-op sensitivity, and it's suitable for adhesive dentistry. This is Dr. Olivi. He practices in Rome. I got a lot of my training just from reading his textbooks. He's incredible. He has a textbook on lasers and endo. If anyone's using erbium lasers and working on kids and dealing with pulp exposures, I highly recommend you get the Pediatric Laser Dentistry book. Even if you're not working on kids, but you're dealing with a lot of pulp exposures, he gives you all of the settings, all of the details you need to know. And then you can start doing things like this. This case, zero anesthetic needed, prepped right up to the nerve, no problem at all, no post-op sensitivity. And not to get into too much of laser physics, but this laser has all of these different settings on it, so you really have to learn what you're doing when you get one of these units. One of the settings is the pulse duration. This laser has 5 different pulse durations you can use. And just so you understand a little bit of what that means, the super short pulse duration, the shortest one, is 50 microseconds. And what that means is you get a really strong burst, and that's what you want to use for if you're cutting through enamel, okay? Or if I'm doing pips. I want a really strong, short burst. Now, if we're starting to get into caries dentin, softer dentin, okay, or into pulp tissue or gum tissue, we want to lengthen that pulse duration because it's not as hard of a burst. It's not going to penetrate as deep. It's going to kind of spread it out a little bit. But the consequence of that is you get a little more heat. Not a lot of heat, but a little bit more. So you have to kind of learn and play with these settings. And once you get good at it, you can do anything. This is a video from Dr. Kalana, who's my laser mentor. And this is him doing a class 5 preparation with the laser. He's using a tipless handpiece, so it looks like it's just disintegrating out of nowhere. There's actually no tip. He just has the laser handpiece about 1 centimeter away, and you'll see beautifully how this caries will just melt away. No, thank you. So he's on the SSP, he's on the 50 microseconds. It's really an art once you learn the details of how to use this laser with all its glory. It's really a beautiful thing. And he's definitely a master. You can really see exactly what you're doing. That entire surface is completely clean of bacteria. The laser's cleaning as it goes. Okay. And the direction of the tubules matter because there's certain areas that are more mineralized and more, and more viscous as far as the tubules and where the fluid is inside. So these are all really important things to learn. And the Lightwalker system offers a variety of parameters and modalities, so you can do so many different things with it. Here's what the screen looks like. And then there's all of this extra stuff, like beyond the basics. Like it's not enough to already learn just the basics, these 5 pulse durations. They do all of this extra stuff, like this QSP mode, which basically is taking 1 pulse and dividing it into 5. All that translates to is that it's kind of like, it's just dividing the trauma of the pulse. So this is how you get to pain-free dentistry, doing cavity preparations without them feeling anything, and you're right on top of the pulp, because they're breaking up the pulses. This is all inside this brilliant computer in this box. You don't have to really worry about anything. You hit QSP, you go to your settings that you learned that are appropriate for the situation, and the patients love it. This is what a QSP pulse gives you. Look how clean that looks, okay, versus some of the other lasers that are out there, another erbium laser. And this is even just a normal setting. And then when you do the QSP, you get this perfect pulse that just hits the tissue and creates this beautiful little crater. So when you have deep caries, like I do here in this premolar, I can easily go through with the laser and just paint that caries away very carefully, watching how close I'm getting to the pulp. If I get a little pulp exposure, I'm not upset. There's no bacteria there. I can manage it by changing my settings a little bit. Okay, but this is a really, really beautiful way to do these deep carious lesions. Now sometimes I will get out a handpiece and I'll touch up, some of my margins, my external margins, but when I'm anywhere near the pulp, you can bet I'm using this laser. It's the safest way to treat these areas. So now we're looking a little better, and then we've got some of our other things like ozone. This is when I'll cup the area with the tooth, and then afterwards you can see how that deep carious area that maybe you were thinking could be a pulp exposure, it's looking pretty good at this point. And you can actually see the little marks where the laser has penetrated the tissue. And this was the pre-op again. So laser cavity preparations, we detoxify the surface up to 300 to 500 microns, okay? We're completely eliminating the bacterial load, and we're ensuring that deeper decontamination. The one thing with the lasers, it does make a little noise. I always try to have my patients wear headphones. Some of them really don't want to. I let them know, hey, I have deep relaxation music to put on you. Your body's gonna heal better if you're in a parasympathetic state. So let's not stress you out with all the noise of the dental office. These are really important things. I use the new comm system for that. So you can crank this laser up and cut through a tooth very quickly, or you can move as slow as you want. So depending on what I'm dealing with and when I'm entering to areas I'm not really sure what's going to be underneath, I'm going to be a little more on the conservative setting. Sorry for the loud noises. So this is when I'm getting a little bit deeper into the area. Could we actually mute the volume for this part? I think it'll be better. Thank you. So I can talk over it. Yeah, so I'm using the laser again as I get into the deeper areas here. I always like to use caries detector once I get close just to see where I'm at, how much is actually decay before I continue on any deeper. And I'm not scared to get out my spoon excavator either, so I show you a little bit of that here. And then once I feel I have everything out, I actually do pips inside the cavity preparation. So pips is penetrating shock waves of ozone water down into the tubules where, well, how else am I going to get in there really? This is an incredible tool to use in these deep cavity preparations or any cavity preparation. And then I hit it with my ozone gas, of course. And depending on where I'm at, if I have a pulp exposure, I will use the bioceramic materials from Brasseler. They have ones that are more liquid, ones that are thicker. I'll show you guys a picture of it in a minute. And then I use over top of that a liner. I use Calcimol by Voco. And then I do my composite buildup. And I'm telling you this, I hardly ever have issues with these teeth. I have patients come in that say, I had a pulp exposure and a pulp cap place and it's sensitive, it hurts when I'm biting. I go in with the laser, I remove the composite, I remove their pulp cap, I retreat the surface of the pulp, I do my system, and they're perfect. So I think it's really just about the bacteria, and I think the laser, it stimulates something in the tooth. It really helps alleviate some of the issues when you have the settings on right. If you have it too high and you're blasting the pulp, it's obviously going to be an issue. But this is what the surface looks like. It's got this really crazy irregular surface, but the tubules are open. So it's actually really good for bonding, but etch is still recommended. And then, of course, you can hit it with ozone, which actually increases the bond strength, according to this study, which I love. And this is from Dr. O'Leavy's textbook. So these are some pulp exposures, okay, that we're going to show you how he treats with the erbium YAG laser. So the key factors in vital pulp therapy is anything where you have any sort of exposure to the pulp, you're dealing with the pulp at all. I think it's pretty much every operative procedure, because anything we're doing when we're drilling on teeth, we're affecting the pulp. But whether you have a small exposure or minimal bleeding, these are all key things that you can probably have successful vital pulp therapy. So when you get into these deep layers, the laser is critical to slowly remove these areas and be as minimally invasive as possible. So these actually show you some of the settings. 10 millijoules, it's a very, very, very low energy use at 300 microseconds. So that's, remember, a longer pulse, 300 over 50, a little bit shorter, you're not going to penetrate as deep, and it's actually, the heat is actually going to help us get a nice coagulation in this case, similar to something you may see with ozone. So I definitely use the combination of the two, and sometimes one works better than the other. This is a paper on pulp capping with the laser, and it does improve the prognosis. And this is a really cool case that Dr. Mary Ellen Chalmers sent down to me from Santa Rosa. A little girl broke off their class 4 entire incisal edge of this tooth, and pulp exposure. Mary Ellen thought she would for sure need a complete root canal. If you look on the right, when I saw her, she had a widened PDL up here. And I went in with the laser and I started removing the pulp tissue. And as I got down to the CEJ, I said, you know, this pulp tissue looks pretty healthy. I'm going to keep this. And so I placed the bioceramic putty. This is the sealer. This is what I use for endodontic therapy. This is the bioceramic putty. It's a little bit thicker. It's kind of got an IRM consistency. And this is what I use over the pulp. And it actually promotes mineralization by the stem cells, by the dental pulp stem cells. And this case worked out really great. You can see this beautiful dent and bridge forming under that pulp cap material. So the little girl was very excited, and her PDL appeared to be intact again. So love that. So pulpotomies are actually, this is published in the JOE, a great alternative for management of symptomatic permanent teeth in adults with deep carious lesions. I was surprised to see this published in the JOE, but promoting, you know, vital pulp therapy as opposed to root canals. This is a really cool case I want to share with you guys from Dr. Randy Garland down in Southern California. So a patient came in, he had to retreat this tooth number 3, but if you look at number 2, this was symptomatic. He had some recurrent decay under that deep restoration. Here's the CT scan of the tooth. So this is the tooth we're looking at, deep restoration near the pulp, PDL's lamina dura look intact. He had to retreat this tooth. There's a miss MB2 on number 3, so he's using the gentle wave system. So interesting, most people are just using the gentle wave system to do endodontics, but he is the pioneer in vital pulp therapy with the gentle wave system, and I had to get a case from him for this lecture for you guys. When he accessed in, this is an inflamed, pulp extension from the palatal canal. So he hooked up the gentle wave system. I'm going to play you a little video of what the gentle wave system is for those of you who don't know. But what I will advise you is that it's an incredible tool in endodontics. So you need to make sure when you're referring out your patients for endo, you're referring to someone with the Fotona Lightwalker laser or the gentle wave system, or both, ideally. You can hit mute again so I can actually just talk through the video. Thank you so much. So the gentle wave system, you actually create a platform and seal over the tooth with this device, and it's using multisonic sound energy and irrigating solutions to move through the tooth, and it literally starts sucking up the pulp just like you see in this animation. I've seen it with my own eyes. It's incredible. So generally you can see how this would be really applicable for endodontics. You can actually suck the entire pulp out of the tooth, keeping everything perfectly intact. And it really does that. I've seen it for myself. And what they're reporting is an incredible decrease in bacteria in the tooth. They left 0.09% bacteria in the tubules. Like, that's pretty incredible numbers. And they're saying even though bacteria can penetrate almost up, and their endotoxins can penetrate up to 500 microns into the tubules, they say they can clean that far. And the same with pips. We can get up to 1,200 microns in the tubules with pips, you guys, and I'll show you a slide a little bit later. So we're actually getting these things cleaner than anyone remembers because we didn't used to do it. Now, this is what it looked like after the gentle wave was hooked on. This is a beautiful pulp stump in the palatal canal. This is the pulp stump in the mesiobuccal canal. You can't really see it because it's tucked around this corner. And then PRF was placed. Nice little mini PRF membrane. Now, this is really important, the PRF stuff, because you obviously have a big membrane when you're using the normal settings. It's actually really important what part of that membrane you're using and what settings you're using when you're doing procedures, especially when you're using a tiny little nugget of this. And I went over that with Randy yesterday as he shared this case with me, and he was like, oh, wow, this is good to know. And I'll tell you guys more about that later. I'm actually having an endo PRF course where we're going to focus on all of the details of that. So this is a bioceramic material he placed over top, followed by composite. And if you look here, this is the follow-up. Okay, here's the two-dimensional, ready for the CT. Look at this amazing dentin bridge formed in the palatal canal. This tooth is vital. PDL is perfectly intact. That's incredible. This is what we're able to do. This is what your endodontists are going to start doing as soon as we can get them all with these devices in their hands and we can educate them. So this is another shout out to Dr. Rick Miron and PRF, and if you're not familiar with it or you're just learning about it, I highly recommend it for every practice there's utilization. Dr. Miron and I did a study where we put PRF on dental pulp stem cells to see what would happen. And of course, it helped them grow more than even PRP, and it also helped them form mineralized tissue like dentin. And even more incredible is it actually counteracted the effects of LPS, which we know is so critical. LPS is driving the macrophages into that M1, that really gnarly one that we don't want. LPS is driving the path into the M1s. So we want to avoid that. So by having PRF, when you have LPS, we obviously had all these cytokines, the IL-1 betas, the ones that we don't like, those numbers are going up when LPS is present. When we added PRF in, those numbers stabilize and drop down. So that's what all these confusing charts show there. So basically, the presence of IPRF significantly balanced the negative effects of LPS, showing that not only did it revert the mineralized level, but it also rescued gene expression of odontoblastic markers. And PRF is an amazing scaffold. You can add anything to it, especially the liquid form. There's peptides, there's exosomes, there's stem cells. All of these things you can add into the PRF matrix. It's the ideal matrix. It's the body's own extracellular plasma. Now, if any of you guys ever taken a sample and you've seen this, where there's this slant in the side of the PRF tube. Has anyone seen that? Of course you have. Because if you look at the way a centrifuge is designed, it's at an angle and all of the cells are slamming up against the side. Well, Rick Miron said, hey, maybe this is actually causing a problem. Let me look deeper into this. He started doing research. And what he found drove him to develop this new PRF machine, which I don't know if I think they have one here. This man's brilliant, I'm telling you. Look at this. You spin the centerpiece, and the tubes actually can flip out. Does anyone understand what this means? We're not going to get all those dead cells on the side of the tubes anymore. They're all going to be in a perfect layer right at the bottom of your fibrin clot. Incredible. So instead of having them on the side and having these cells have to kind of fight for the direction that their weight is bringing them, now they're all going to be perfectly aligned right in the middle. I'm just like, Rick, who are you? And so he motivated me to do this PRF class in endo, and we're going to be doing that August 3rd in Los Angeles. So if you guys are interested, my website's askdrval.com is the easiest way, or you can just Google, and there's actually like a little course tab. I'm not doing a lot of courses yet. I will be doing a couple throughout the year on integrative endodontics, getting into some of this in more detail, and this one will be all PRF, okay? And I know you guys want to talk about the root cause a little bit, so what time am I supposed to end? 9:15. Oh, good. So I have my full hour. Perfect. Because they were trying to cut me short, but now we actually have time to go into this. I know you guys are all wanting to talk about it. So this is why endodontists really don't understand what you guys are talking about, what I'm talking about. They look at us like we're crazy sometimes. Because I did this case 10 years ago, and despite this anatomy here that we all know is present, let alone all of the tubules, because I was using standard needle irrigation and some sonic activation, which definitely helps, the endo activator. That's what I did my research on in my residency. But when I get a result like that, like, I'm happy. I'm feeling pretty good about this. But now, in my new enlightened world, I'm like staring at this furcation. I can't let it go. What's going on in there? Something. What's inside there that I don't know about? And this is what I'm seeing all day, every day. I'm opening, 90% of my practice is retreatments. I'm opening up these infected root canals, even when they look perfect. Even on a CT, a lot of them are loaded with bacteria. So I'm asking myself, what's going on? How can we make endo better? Unfortunately, we're at like this division point right now because we're dealing with a lot of root canals that were done in the past and they were done poorly. But I'm telling you guys, I'm seeing it, I'm in here, I'm living this every day. What we're able to do now is on a whole nother level. Everything now, moving forward, we have the option to refer these patients to the right people and get them quality care and allow them to save their teeth. And I'm going to talk to you guys about Weston Price and all his wise words in a few minutes here. I know it's a problem. I'm the one smelling and pulling. I'm doing this, you guys. I know it's an issue. I just really want you to understand. I know what's going on. The endo knows what's going on too. All of his endodontists. They know that their files aren't cleaning all the walls. So when you're in there filing away, I know a lot of you guys do endo. We saw the survey. Half of you are doing root canals. Okay, so listen up. The filing is not doing much. You're just creating more debris down in the canal. Do we need to do it? Well, of course, we need to obturate, right? So we have to do something, but it's really a matter of irrigation is the key and how you're irrigating. Because the traditional ways of putting a needle down into the canal, you're only cleaning about 10% of the bacteria out of the tubules. The bacteria can maybe get 500, some papers even say 1,000 microns in. The standard needle irrigation is only cleaning 130 microns into the tubules. So we're just packing everything in. And if you're not using EDTA, forget it. EDTA is going to open the tubules up, EDTA. I take for granted I learned so much of this in my residency. It's critical for root canals procedures. If you're doing root canal procedures, you have to do final rinses with EDTA and then go back with your disinfecting solutions too so it can actually penetrate into the tubules. And of course we have this crazy anatomy where no one's getting that with normal techniques. And this is what a stopped up tubule looks like. Okay, bunch of debris, a huge thick sweater on this wall in here. And these are what the little bacteria look like that are living inside. I mean, this surface is clearly much cleaner than this surface. This is a flat picture, and this is like you're looking at it from the side on the left. And we know that there's a connection to systemic diseases, and this is in the JOE, the Journal of Endodontics, you guys. They know it too, but there's a difference in what we're talking about. There's a difference in what they're saying in root cause and what's actually happening. The root canal itself is an anatomical structure. Then you can have a root canal infection. That's a problem. Then you can have a root canal treatment, and that's either done properly and heals the problem, or it's done poorly and helps the problem persist and actually can make it worse because now you get these more nasty bugs growing in. The problem is that the public doesn't know the difference between a root canal, anatomical structure, a root canal treatment, and a root canal infection. Because in this movie, they're just saying root canal, root canal, root canal. So no one knows the difference. I've literally had health practitioners come into my office and say, I didn't want to have a root canal because that's bad, where they have a giant infection in their jaw that they've been walking around with for 3 or 4 years trying to avoid a root canal. Do you see the problem? Do you guys understand what I'm saying? It's critical that we educate our patients and that we change our terminology. Even as I was writing my response paper to this, which you can find on my website, I'm saying root canal when I'm meaning root canal treatment. I mean, it's a major problem, and we really have to address this immediately if we're going to change anything in dentistry. So we know that there's a systemic connection between root canal infections and coronary artery disease. Okay, it's key. I want you guys to even watch back and listen. There's a big difference. So when you have chronic apical periodontitis, you're 3 times, more likely to get coronary artery disease. This is not a cause and effect, you guys. This is a correlation. There's something going on in the immune system, in the terrain. We have low-grade chronic inflammation. Our markers are elevated everywhere. So when we have a little problem, our body's attacking. And now we have an infection here. And we've got a thrombus here. And we've got diabetes. And we've got mental disorders. It's all cumulative from these inflammatory markers that are rising from a bunch of different things. Many of them is our diet. It's not the bugs that are the problem. We're 90% bacteria. Okay? We have to fix the terrain. Remember this slide. Don't forget it. This is my favorite slide. We've got to clean up our body. Dr. Weston Price, quote, degenerative diseases, not only because of dental infections, but also because other overloads. One of the most important is faulty nutrition and diet. A normal rat exfoliates an infected tooth put under their skin in 6 days. A rat deficiency diet takes 40 days. Do you guys remember those studies? If you're healthy, boom, you're getting rid of that thing. If you're not healthy, it's going to cause some major issues. These are quotes directly from his book. So everyone, when you're going online and you're reading Weston Price quotes and you think you're part of this crew, I want you to actually order the volumes and read it for yourself, because this is what he says. To recapitulate briefly, individuals, instead of being similar and therefore comparable in their susceptibilities to infection, divide themselves into 3 groups: non-susceptibles, acquired susceptibles, and inherited susceptibles. The tendency of an individual to develop both general and systemic involvements has a direct relation with and proportion to the susceptibility. Well, that makes sense. So what are we talking about in our New Age knowledge base here? Let's see if we can go back. Amongst failing root canals with apical periodontitis, when you looked at cases that had lesions and you took the genetics on that person, 70% of them had an IL-1 beta polymorphism, or a SNP. That means that they have an issue. They're making too much IL-1 beta. Do you realize it's not the root canal necessarily that's causing the problem? It's yeah, we have some bacteria. Our bodies are brilliant, you guys. We can deal with a lot of stuff. And that's why you can see one patient and they have a ton of root canals, they have no infections and no problems, and someone else, you can't do any of those procedures on them because they fail immediately. It's their genetics and it's their epigenetics, really. 70% of these patients with apical periodontitis had the IL-1 beta SNP. I hope that makes sense to you guys. And we can actually test for that in our office. Oral DNA, you can do more than the periopath. Celsus 1 actually will give you that IL-1 beta information. It's a whole different panel. Let's go back to Weston. The condition of safety or danger, he's talking about root canal treatments, will be dependent quite largely on the defense factors of the patient. And with a given tooth, some individuals will, I believe, be relatively safe, while others may be in definite danger. I am not ready to draw the line so rigidly as to state that all root-filled teeth should be extracted for every patient. And this is an incredible paper out now on meta-inflammation, that chronic low-grade inflammation. I'm going to try to read just a couple snippets from you. Adipose tissue is now considered a dynamic endocrine organ. It expresses so many pro-inflammatory cytokines like TNF-alpha, IL-6, and IL-1 beta, and reactive oxygen species. Note that these same cytokines that are expressed in meta-inflammation are expressed in oral infections. Moreover, genetics controls lipid-related transcriptome and the differentiation of monocyte and macrophages. Additionally, genetics influences cardiometabolic disorders. And this creates a confounding relationship among oral infections, meta-inflammation, and genetics. Therefore, future studies must elucidate whether oral infections can increase the risk of these cardiometabolic disorders independent of the aforementioned confounding factors. You see what I'm saying? There's a correlation. There's not a cause and effect. There's a correlation between all of this inflammation in the body. This systematic review in the JOE, they know that. This is what they're saying. There's a correlation between systemic illnesses and endodontic outcomes. There's a connection here. It's no secret, but it's not a root canal. It's a root canal infection. It's a persistent root canal infection. These are the things we need to be really, really wary of. We need to either send them for a proper retreatment right away, or they need to take the tooth out if that's not working. And you have to have this new technology, or the person you're sending your patients to has to have this technology. There's no buts. Find someone with this, either the gentle wave or the laser. Find an endodontist that's using them. They care and they will clean the teeth out properly. And I'm really back and forth between sending them back to me for ozone, and that transition, that chance for leakage in between offices and everything, I think it's actually better to just seal the tooth. I'm spending the hours right now researching at UCLA, researching ozone therapy. I'm looking for that result where I can say, hey, this is it. But I'm telling you right now, sodium hypochlorite by far is the best. I'm doing this for myself because I wanted to use ozone water. My scrubs are all destroyed from little bleach spots. I don't want to use it anymore. But it's the only way I can go home and sleep at night knowing I'm cleaning these teeth out properly. Yes, the ozone helps. Yes, it's safe in situations. Yes, the gas is amazing. But if you want to clean these root canals out properly, I strongly advise that you send to an endodontist that is using these devices. It's the most important thing or if you want to learn how to do it, come talk to me. I have courses. I will teach you every step of the way how to do the best endo of your life, but be ready to buy some equipment. Clearly, a CBCT is critical. Look at this case on the left. You can barely see this giant lesion that's existing in the CT scan. This is huge. You have to have a CT, and any previous root canal should have a CT scan done on it. This is what the laser looks like. This is what we're working against here. And this is an incredible slide coming up. This is taken from some of the guys in Europe that are studying the laser. Dr. Demore and Dr. Olivi. I'm going to give them all their credit. This is an ultrasonic tip going down a premolar model. Can you see this is a canal here? This is a canal here. This is a nice isthmus in here. Or this could be the mesial root of a lower molar. This is the same thing with a laser tip right here at the orifice. This is a thick biofilm. I want you to glance at the left for a moment and see how it's going to slowly start chipping away this biofilm, and then just imagine how long it's going to take for it to get through. And then I want you to don't miss it on the right because it's so fast you'll literally miss it. This laser is going to annihilate this biofilm here. The one on the left is working. It's on. Look at that on the right. Look what that did to that biofilm in literally 10-15 seconds. So imagine if you're doing it for minutes. We're cleaning the tubules. We have the SEMs. We have the studies. Immediately after treatment, laser activated irrigation, which is a generic term for PIPs, resulted in no detectable growth in all samples. After 48 hours, we detected no bacterial growth in any incubated samples versus the control where, of course, they found bacteria still in there. And this is how the tubulars are getting cleaned. These are a bunch of different methods that are cleaning the tooth, and then they put dye in to see how far can we push the dye in these clean tubules. This is a brand new study. Look at pips, literally completely to the CEJ. Now, of course, we'd like to see that all the way around, and believe me, we're working on it. These guys are nerding out in Slovenia right now, trying to figure out how to get this entire tooth blue, because then I'm feeling really good. Let's go back to Weston. Root fillings rarely fill pulp canals sufficiently, perfectly to shut out bacteria completely. I know this is another issue, the obturation, right? Root fillings usually fill the pulp canal much less perfectly, sometime after the operation, meaning it shrinks due to contraction of the root filling material. It is not proven that it is absolutely necessary for the teeth to be perfectly sterilized or that they be perfectly root filled in order that an individual may not develop systemic involvement, since under favorable conditions, the patient may provide an adequate defense system against the material. So in a healthy individual with a good terrain, it doesn't really matter. It really doesn't, and that's why root canals are working so often. So we're like, how the heck are we getting 97% success? I don't understand when we're leaving all this stuff behind. Because in general, we're amazing physical creatures. But some people are sick and they're struggling, and we really need to help them out. So if they can't take their teeth out, if they took the bisphosphonates IV, if they, if something's going on and we can't take that tooth out, we have to do the best damn endo that we can do. And I know you guys know that, and you know how to do that now, or you know where to send them. And we have to make sure the seal is proper too, because this is a thing. This is gutta percha, this is sealer, this is dentin, and these are the cracks that the bugs are loving. Okay, so if you didn't clean them out, they're definitely going to start growing in there. So I use this bioceramic material by Brasler. You guys, it's incredible. I know a lot of people are using it. It's incredible. You inject it in, and then you just stick your thinnest cone possible. I would use the thinnest cone you can because I want the sealer there. The gutta percha is just your space holder. Okay, I'm actually not using gutta percha in 99% of my cases. I'm just using the sealer, but it's really hard. It's really hard to learn. We would need to spend a good amount of time together for you to get that system down properly. So what I'm teaching right now is fill the canals with the sealer, tiny, tiny little cone just in the middle to drive it where you need to go. Most of the contact, these cones are a lot bigger. Okay, obviously I didn't take this slide, but I would use a tiny one. The sealer goes everywhere. This stuff sets, it slightly expands. That means it creates little finger projections, a couple hundred microns into the tubules. So now we're sealing off the tubules that we just cleaned. I'm feeling really good about this. I almost had a nervous breakdown a few years ago when I learned about all of this. And I've just been on a mission since saying, how can we make this right? And hallelujah for Fatona. I'm just like, thank God. This is me injecting the sealer into this tooth, just so you guys can see what it looks like. Hopefully it'll play. Always have an issue with this. Okay, so I'm putting it in MB1. It's coming up MB2. So I don't need to do much. I'm just injecting it, and it's so liquid. And now they have a high flow version, which I'm loving even more. It's just filling that whole area up. And then I'm getting all these sealer puffs going everywhere just from a gentle injection system that I'm using. Look at this. Look at all those lateral canals that are filled with that beautiful bioceramic material. And I've seen some cases like a canine was like weirdly fractured, so I had to take it out. And I took it out. I wish I would have taken pictures. I saw little white dots around the apex. It's getting there and it's setting. This material sets beautifully. Hard as a rock, sealed at the orifice, no leakage. It's like perfect white. It looks so clean. I love the white. It's like bright white. It just correlates with clean, right? This is the kind of fills that we're getting. I'm not instrumenting that. These devices are cleaning that for me. I hook up the device, I'm using the pips, I'm getting these amazing areas cleaned out and sealed. These retreatments that I'm doing, look at this, 3 exit points here that you can see. Who knows what the other ones are that are around the corner that you can't see. And I'm using pips and PRF for these PRF cases. So I really wanted to show you guys this. This thing is incredible. So this is a CT. I'm going to move through the slices. This is a huge lesion, okay? I did a root canal on this tooth. It was lateral. The reason why it needed a root canal is because there was an impacted canine there, okay? And they put a bridge on this lateral. It's a lot of force for a little lateral. It's not supposed to take all that force of where a canine was missing. So it died, and there was a huge lesion there. Look at this thing. And this is the canine on its side, if you're not used to looking at CTs. I did my root canal. I decided, you know what, I'm going to remove this. This is almost like a cyst. It's been in this woman's mouth probably 30 years. Okay. I went in, I cleaned everything out. I used the laser. I cleaned out the crypt. I put PRF in there. This is a 6-month recall. I never take CTs that soon, but something in my gut said, you know what, let's get a limited CT. Let's take a look at this. What? Look at all this bone. I'm going to go back to another slide where you can see it. Look at this. 6 months, just PRF, no bone grafting material. I'm sorry, the body's happy here. I think the body's happy that we did that. If I'm not seeing bone growth, if I'm seeing recurrent inflammation in the body, of course there's a problem and we need to take that tooth out. But when we're seeing this sort of response in 6 months, I think the body's okay with these materials and these procedures. And it's important to keep our teeth, you guys. The loss of teeth reduces masticatory performance. Chewing takes a little bit longer. Particle size of the bolus becomes larger. The nutrition starts to get affected. We have to think about all these things. Mastication for the mind. This paper is amazing. Impaired mastication causes malnutrition and negative effects on cognition and daily activities. They did this out of a nursing home. How many teeth are you missing? What's going on here? It's actually a real thing. It affects our cognition. And we all know that this is not the answer, okay? Now, I know this is an extreme case, but really, you guys, we really need to be mindful. We need to take out teeth that are infected, and we need to find ways to clean and save teeth that can be properly saved in patients that are healthy enough to withstand that procedure, and that's critical. And we'll talk about that much more. I have 2 courses coming up June 8th. This is in LA. Okay, you can email, you can go to my website, you can call my office. Everyone will help you if you want to come in. This is a full day. We do live patients. You get to watch in like 3D. We have the Moravision. It's pretty cool. It's nerve-wracking for me. I'm sitting here like doing a procedure in 3D, but it's going great. Everyone's loving it. The patients are happy because they're getting a free treatment. And then again, the PRF course is August 3rd. So I have like 3 minutes. Can we take maybe just like 1 question, 1 or 2 questions? No, we're not allowed. We're not allowed. So we're going to finish. So we're going to finish early. Thank you guys.